Hi, everyone, and welcome to the Cure OM Symposium. My name is Sapna Patel. I'm an associate professor and director of online media and the Uveal Melanoma program at MD Anderson Cancer Center in Houston, Texas. It is my distinct honor and privilege to be able to come to you virtually today and discuss some of the treatment progress that I think we've seen over the last few decades in uveal melanoma. I just want to caution everybody, it's a fairly long talk, so I'm going to go quickly, but I hope there is a theme of hope and exciting and interesting research that is happening in uveal melanoma. So this is a cumulative frequency distribution plot. And at the top, what you see is the typical age of surgery for uveal melanoma. And what we mean by surgery is treatment of the eye. You know, it's either radiation or enucleation and involves some sort of surgical maneuver. So the frequency of age at the time of surgery for primary tumor and then age at death. And, you know, we want these gaps to be, these curves to have a pretty big gap between them. And historically, you know, there's not much, there's maybe like a 10-year gap or so between kind of the age at diagnosis or the age at surgery and the age of death. So we're trying to improve that. What you see below is something called a jittered scatter plot. This is a plot of height of tumor and basal diameter of the tumor. This is in almost 300 patients where they looked at what is the correlation basically of the tumor size dimensions. What we know historically in uveal melanoma is there is a predictive power in screening tests. And, you know, essentially mortality in uveal melanoma segregates by age and by tumor size. And so if you look on the left here, this is an old paper now, it's more than 20 years old, but if you look on the left and you see the normal population with life expectancy, you can see in uveal melanoma what happens is patients who are greater than age 60 perhaps tend to have a higher mortality and a lower survival than patients less than age 60. But what's really striking, what we've known for some time in this disease, is that mortality also segregates by tumor size. And so a small tumor typically does better than, say, a large or even a medium tumor. What you see here is something called a cumulative incidence function or cumulative incidence ratio. So if you're diagnosed with the uveal melanoma at time 0, how many months after time 0 what proportion of that patient population will develop metastasis? And essentially, large tumors, as demonstrated by the hashed curve here, they have a higher incidence of metastasis at kind of every time point after diagnosis, 6 months, 12 months, and onwards. Larger tumors essentially approach 50% of them having metastasis. Medium tumors fare better. Just recapitulated here, if you look at actual longest basal dimension cut points, and here it is greater than or equal to 16 millimeters, essentially a fairly large size tumor. In blue here, you can see the hashed line is a less than 16 millimeter tumor, but a height greater than 8 millimeters. So they also have an incidence of metastasis approaching perhaps 35% over 10 years. And then smaller tumors, and this is not small by any means, but these are tumors with less than a 16 millimeter basal and less than an 8 millimeter height, tend to have less incidence of metastasis. This is some multivariate, what's called a Cox regression. They looked at different factors: age, gender, was it the right side of your body, left eye, laterality, all that kind of stuff. And they said basically what was associated with mortality after metastasis. Does it matter if you were Caucasian or Hispanic or what? No, really the only things that really fell out were if you had treatment or no treatment. Patients who got treatment, that first row, they did better than patients who didn't get treatment, with a nearly 60% to 70% reduction in mortality. And the patients who had liver metastasis unfortunately did not as well as those who did not have liver, so extrahepatic metastasis. It's fine. We understand that that's not a very common scenario to have extrahepatic metastasis only, but it turns out that group does do fairly well. And then here's a cumulative probability of survival after diagnosis of metastasis. Again, if you do treatment, you're going to live longer, but we want to actually see that dark blue line get kicked out much farther. We don't want to see it just a few years away from no treatment. We want to see it grossly separated. Survival after metastasis diagnosis, again, we can do better, but those patients that have extrahepatic or non-liver metastasis seem to fare better than liver metastasis. And then here is just periodic surveillance of about 4,000 patients amongst a variety of different trials. Actually, I take it back. This is not the 4,000 patients, but this is a variety of different trials from the 80s and 90s and 2000s looking at median survival for metastatic disease. And actually, really the theme here is over the years, this has gotten better. So we're really now approaching much higher numbers of survival from the time of diagnosis. But you know what I want to tell you about, that's our past research. Where are we learning and where are we going in the future? Really has to do with biopsies, and everything we know about uveal melanoma comes from tumor tissue samples, right? Either the enucleated eyes. Enucleation is a very uncommon choice. Most patients are choosing to have radiation, so there's no tissue to study. There's no biopsy, there's no surgical specimen. It's radiated, and then we just have to wait for metastasis. And once somebody metastasizes, we need a biopsy. But why do we hate them? And again, this is an eye. So this is an enucleated eye. Here's the big tumor in the middle with some subretinal fluid you see here. Here's the lens, what's called the cornea up there. And this nice, what we say in medical terms, juicy tumor sitting here. Well, that's great if the patient gets enucleated, right? A lot of tumor to study. But guys, this is what a small uveal melanoma looks like. So this is an eye facing the other direction. Here's the iris here. So this eye facing the other direction, here's a small tumor down here at about 5 o'clock compared to this big one here that's encompassing essentially most of the eye. Look at this tiny little one down here, so far less tissue to study. This is a liver metastasis resection. So a really chunky resection specimen that we get here. And they put it on like a thin deli slicer, if you will, a deli meat slicer, but it's for human tissue. Sliced it really thin and put it on a slide for us. Here's a big nodule of tumor right here sitting in a bay of normal liver tissue. And this is a lung metastasis that was removed. You can tell it's lung tissue because it has a lot of aeration. Those are alveoli where oxygen and carbon dioxide are exchanged. And then there's a tumor sitting down here in the specimen, and actually some sitting over here as well. But this is what we actually get from biopsies. This is core needle biopsies, where we put these tiny cutting cores into the liver, say, and pull a trigger and get these cores out of the tumor. And this is a core that as it was coming out, it got fragmented. So here's the tip of a piece of a core. Here's another piece. Here's a piece that kind of got sheared off to the side. This core right here actually probably belongs to this sample up here. And then a second core that came out down here. It's actually a pretty good sample, two pretty continuous nearly cores, but very little tumor tissue, it turns out. Here's another one where we asked for, gosh, like 5 cores or so, and you can see one continuous core here, kind of another that folded on itself as it was coming out of the needle core. Here's some others here, and then some others. And so we got about 5 cores from this one. So quantity more, but actually turns out there's not a lot of tumor in this. Beautiful 3-core liver biopsy here. You see 3 really long, continuous, well-preserved cores from a biopsy. Essentially what happens is they put the core needle in, and then they poked 3 times and got 3 beautiful cores for us. But again, if you just zoom in at this section of these cores right here, you'd say like, gosh, boy, that looks great. Oh, turns out not all of that is tumor. You know, at low power view, you think, oh boy, this is going to be good. No, turns out up at the top, that pink stuff is just necrosis. It's nothing viable. It's dead tissue. On the top of the panel, this is fibrotic tissue. This is scar tissue. This is just, you know, nothing, no tumor there. The only tumor is this little bit down at the bottom. So if we go a little higher up in the core specimen, you see, okay, here's some normal liver next to some fibrosis. Here's some viable tumor in that top core. And really, we had our pathologist annotate this, and look at this, 3 beautiful cores. You heard me get so excited about this specimen. We only have about 40% tumor in these 3 cores. 60% of these cores did not have tumor in them. So, we really, we ask for these biopsies, and we will often ask for multiple passes and multiple cores because we are so familiar with this situation. Had we just gotten one core, for example, and that one core was, let's say this first one here, all the tumor was sitting down at the bottom. There was mostly normal liver and necrosis up here, necrosis and fibrosis. The middle core had tumor at the top. Now it's quite possible it got inverted when it was coming out of the core needle, right? That these three blue areas actually lined up but it doesn't matter the orientation of it. But this is exactly why we ask for multiple cores, is because oftentimes you can only count on about half of your specimen having viable tumor. Here's much smaller cores, if you will. If you look, these are much shorter and smaller core fragments. And if you look at these, my goodness, where is the tumor in some of these? Look at this one here. If this yellow one was the only one that we got, if that was the only biopsy that was obtained, there's actually no tumor in that specimen. So that's troubling, that really you're seeing mainly necrosis. Now, I actually do think there might be a smidge of tumor at the edges here, but really you see the point that only maybe this top one here looks like it's got a great amount of tumor. Not much I wanted to say else about here, except that just be careful when, when we're looking at these under a slide, that there's often a lot of fibrosis that we see admixed with tumor. Here, the tumor is just like these little dark clefts that you see here, and the rest of it is all fibrosis, and then the pink stuff necrosis. So, we don't always know what we're getting until we put it under a microscope. So some research that's been completed that I think really shows we're making big progress in uveal melanoma has to do with telling us about these tumor biopsies and where is the immune system in relation to the tumor. We know the biggest promise is with your own immune system fighting cancer. So where is that immune system when it comes to these tumors? This is a uveal melanoma metastasis that has no T cells, no lymphocytes in the sample. And so this is something we would call lymphocyte poor, or immune desert, if you will. Here's a sample that actually has a mild panel. If you see these kind of brownish staining cells, these are some lymphocytes there. You've got a small amount of lymphocytes in a nest of tumor tissue. And then here's some highly infiltrated tumor samples. On the left, if you look, you're seeing a nice imbibement of these nice sort of small leukocytes, T cells, lymphocytes, if you will, white blood cells inside admixed with tumor tissue. And then here in this one, you see it kind of meandering throughout. So this is a tumor with high lymphocytic infiltration. But, absent, medium, low, medium, or high, that's all pretty relative. And when you look at uveal melanoma, compared to skin melanoma, a low or a poorly infiltrated sample, even in skin melanoma is still going to have some infiltration of T cells. We're looking at the brown dots here. Whereas if you look in the middle, kind of what we call an intermediate or a low, medium infiltrated tumor in uveal melanoma, again, pretty scant, but a low, medium in cutaneous has far more T cells. A high T cell infiltrated sample in skin melanoma, much more infiltrated, and in uveal, a high one is still actually log level lower than what you see in skin melanoma. So we looked at other markers in the immune system, and that holds. What you see in skin melanoma is not necessarily what you see in uveal. So they're similarly infiltrated, if you will, meaning there's absence, medium, and high level of infiltration. There is a difference in the PD-1 expression though on these T cells, and frankly the PD-L1 expression in uveal melanoma can be thought of as more or less absent in metastatic tissues. We wanted to look at this immune infiltrate across a variety of uveal melanoma metastasis, and so we looked at about 25 liver tumors, 9 lung, 13 soft tissue, and 4 tumors from other sites. And what we saw is essentially the CD8 or T cell population was not that different statistically between these 4 groups, but this is very compromised because of the small number of samples that we have. If you look, the trend line for median for this liver group in red is higher than the trend line or the median line for lung, soft tissue, and other, but statistically there was no statistical difference. But you can see just even by where the dots are scattering, that there's a trend for more of an infiltrate in liver. And that's a good thing, right? Because liver is where this cancer likes to go, and it's where we want to generate immune responses. So good to see that you can get your T cells into the liver. We did a very quick pilot study to say, well, do your T cells change in response to treatment? What's your CD8 level, your T cell level pre-treatment and post-treatment? And then CD3 is just a master T cell population, 68 macrophages. And, essentially these markers may change after treatment for metastatic disease. So it is important for us to know what these mechanisms are that increase T cell infiltration. And so we wanted to validate essentially this pilot work, and we looked at a bunch of tumors and said, okay, we're going to look at their T cell population, total T cell and CD8 T cell macrophages, and then some of these other markers, and just ask the question at baseline, do they have more similar numbers than they do at progression of disease? Is there more of a change at progression? And by the way, these were all immune therapy treated patients. And so did they have a big boost in their infiltrate? Indeed, yeah, they sure did. So CD8 numbers really went up in about 3 of our cases, up to 700, 2000, 1950. I guess I can't say up to 700 since we didn't have it in the first patient. But the total T cell populations in many of these also went up. Macrophage population, which is often not a great cell to see in the tumors, that one also went up. So it may be stifling the T cells from doing their job, and then some other regulatory markers. And like I said, you can essentially think of uveal melanomas as a PD-L1 negative tumor. Let me just go quickly because there's so much more to cover here. We looked at CD8, this T cell population in primary tumors versus metastatic tumors. Or primary tumors less infiltrated? If you had a lot of T cells in your eye, you'd have an inflamed eye all the time. You'd be kind of rubbing your eye. If the anterior chamber was inflamed, you'd be potentially having blurry vision if the posterior chamber or retinal area was inflamed. And so hard to see in that graph on the left, but actually metastasis do have a higher infiltrate than primary tumors. It's just, again, not statistically significant, it's more of a trend. And you saw this slide by metastatic site. We looked at tumor type, primary versus metastatic, and is it just the CD8 T cells, or is it across all T cells? Well, really, there's a difference in the total T cell population, metastatic tumors having numerically more T cells, and specifically CD8 positive T cells. That's what the star means. More macrophages too, though. And remember when I said that macrophages are sometimes stifling of an immune response. More regulatory cells, and more a trend towards more PD-1 on the T cells. I'm actually going to skip this. We didn't see any significant differences by tumor site or by treatment. Let me just go quickly. Immune responses. So we want to know what makes a patient a responder to immune therapy versus a non-responder, right? How can I look at your tumor tissue and say, you need to get on immunotherapy, you look like you're going to have a response? Well, we did a quick little study of 6 patients, 4 of whom did not respond to immune therapy and 2 whom did. And we had pre-treatment on all 6 of these patients. In 2 of them, it was their primary eye tumor, and in 4, it was their metastasis. And actually what you see here in this volcano plot and then the ingenuity pathway analysis, there actually is a signature in the baseline tissue of patients who will respond to checkpoint blockade. And that signature seems to have an interferon gamma signaling pathway. And it's very similar to what some colleagues found in skin melanoma with the expression of a gene called CDH1. A gene fell out for us, though, a gene called SOX1, where we noted that SOX1 high patients did better than tumors that did not express SOX1. SOX1 is in the interferon gamma signaling pathway, suggesting that patients that have interferon gamma in their tumor at baseline are the ones who will respond to checkpoint blockade. So when we ask you for a biopsy sample, it's not to make the diagnosis of uveal melanoma. Of course, we need that, but it's really to ask this question: does your tumor have a baseline signature that suggests immune therapy is the right choice for you? If you don't have that, you should not waste your time taking immune therapy. In fact, we should do something to turn on that interferon gamma signature. And there are things we're doing for that. Very quickly on liquid biopsies. Liquid biopsies is this idea that we can sample the blood and get bits of tumor intact cells, whole cells, circulating tumor cells, CTCs, or bits of their DNA from perhaps dying or still sort of replicating tumor cells, if you will, and we catch that in the bloodstream. We did a pilot study, basically the question is, can you find CTCs in uveal? Yep, you absolutely can. You can find them in class 1 patients, class 2 patients, and you can find them in metastatic patients. And we check them longitudinally because as you're following a class 2 patient who's not yet metastatic, does that number go up? We found that at least one circulating tumor cell was identified in 75 patients before they developed metastasis or at the time they developed metastasis. It's a powerful tool when you think about it. That means there's a blood test 75% of the time in a obviously tiny study here that said, yep, metastasis is either here or it's about to come in the future. So that's powerful. And so this is just graphical representation. Here's a patient who developed distant metastatic disease. So if you look at this patient over here on the top left, these patients had 0 circulating tumor cells at the first draw, had 1 circulating tumor cell in the tube of blood at the second draw, almost a year later, and then 6 circulating tumor cells at draw 3, but actually did not develop metastasis for almost another year. So that tube of blood that said, hey, there's 6, that gave us lead time, right? That tells you ahead of time that the patient may go on to develop metastasis. Same with patient 12, had 1 circulating tumor cell, 1 circulating tumor cell, then 4. And at that time, that draw 3 was also the time that they developed metastatic disease. So it was there at the time of metastasis. Of course, had we drawn them a month or 2 earlier, would it have preceded? We don't know. It's all impacted by how frequently you go checking. In this patient here in the middle, interestingly, they had a high number of circulating tumor cells that actually cleared and went to 0 and then developed metastatic disease about a year later. But you can see that year later, we actually didn't check blood again. So I would be interested to know what was the circulating tumor cell count the time they develop metastasis. And then we have a couple of non-secretors here. If you look at patients 3 and 29, these patients had never secreted circulating tumor cells, staying at 0, yet they developed metastatic disease. So you could be a non-secretor. But again, 75% of patients, we found it before or during disease progression. And just, trend-wise, a metastatic patient is going to shed more circulating tumor cells than a non-metastatic patient. It's a little bit of science of the obvious, but it's important, right? Because this means as you're metastatic and we want to do scans to check how the tumors are doing, one other alternative might be check blood. And as that number is increasing, you're metastatic, you're shedding more, the number might increase to correlate with perhaps what you're seeing radiographically. And then tumor DNA, I'll just keep it brief, but here we knew the GNAQ, GNA11 status on 7 of our 8 patients, and we found corresponding mutations in their blood. So this is very exciting. Concordance is what we call that. I probably don't have time to go through this, you guys, but really it's the question of, does this circulating tumor DNA count increase with progression? The answer is yes, no, and maybe, if you will. In these 3 patients, it really markedly increased as they became metastatic. And then 2 last slides here. I wanted to talk about the uveal melanoma microbiome. The microbiome is your bacterial load in the body, and it's the symbiotic bacteria. It's the good bacteria, but your good bacteria actually affect your immunity, and they affect your immune response in cancer. And so we collected the stool on about 15 uveal melanoma patients, and we're looking for differences in the bacterial content or microbiome of responders versus non-responders. In a very tiny data set so far, we didn't see it, but we're actually enriching this for a bunch of uveal melanoma immunotherapy responders to see if we can really pick out. In skin melanoma, I can tell you, you can see it. You can see a real difference in the bacterial load of responders to non-responders. So we may ask you for your stool at some point, and there's reason for it because bacteria matter. And then finally, we're growing what's called uveal patient-derived xenografts. Patient-derived xenografts is where if you are going for surgery or having a biopsy, we take that cancer fresh, that uveal melanoma fresh before it has a chance to die. And in the needle or from the surgical sample, we implant it into a mouse. And in that mouse, it starts to grow up into a tumor on their flank, on the side. And we have successfully passaged uveal melanoma tumors from 3 patients who underwent metastatic liver resections with my liver surgeon here, and they are growing beautifully in mice. And so those mice then propagate, they give rise to the next mice, and you get the tumor out and you put them in the next mice and you put them in the next, and then you study. You basically treat those mice with drugs and watch if those tumors grow, shrink, what do they do? You cut those tumors out, you study them. A lot of cool research we can do from this kind of stuff. After these mice have been grown, we now need to fingerprint the DNA and essentially molecularly characterize, make sure that that tumor matches from the patient we got it from. And then we're going to do a whole host of experiments on it, basically test different drugs and figure out the next good clinical trials. So I hope that gives you guys hope. I mean, really, that's uveal melanoma in the past. I feel like we've come such a long way. We're doing a lot of cool things in the present that will impact us in the future. So thank you very much, guys. I hope you have a good webinar, web conference. Bye.